Hey, so good evening, everybody. It's such a pleasure to be here. I would like to thank SDI for sponsoring this CE course and for Catapult Education for hosting us. It's a great pleasure. I will be briefly talking about restoring aesthetics and function in fixed prosthodontics and what do you do to get long-term success. The successful outcome of any treatment you do is not by chance, it's by planning. So any work that you do, regardless if it's a single crown, multiple crowns, or full mouth rehab, it's always planning between you, the lab technician, and the patient, and to understand what the patient wants, to relay this to the technician who can in turn provide you with a highly aesthetic outcome. If you fail to plan, you're planning to fail. That's what Benjamin Franklin said. And that's why it's important for us, whenever we treat a fixed case, is to go through this checklist. First of all, the diagnostic and treatment planning, choice of materials and shade selection, tooth preparation, tissue management and definitive impression, provisionalization, and cementation. So let's start with the diagnosis and treatment planning. The goals of prosthodontic rehabilitation is to emulate nature. So what we're trying to do is to replicate the intricate details and the delicate nuances that found in natural teeth. And basically what you're looking is to get the teeth back to the aesthetic shape. You want the function to be restored and you want everything to look beautiful. So this can't be really just by chance, it's by design. If you look at the definition of aesthetics in the glossary of prosthodontic terms, aesthetics is the theory and philosophy that deal with the beauty and the beautiful, especially with respect to the appearance of a dental restoration. It is the science of harmonizing our work with that of nature, making our art inconspicuous. Only 30 to 40% of adults with inharmonious anterior teeth are not satisfied with their smile. But when you look at dental aesthetics, you have to basically look at the practitioner's perception and also look at the patient's perception. Now, our perception of aesthetics is not really important. It's the patient perception that is very important. What they see and what they perceive is different than what we see and what we perceive. It doesn't matter if we find our restoration beautiful. If they don't, then you have a problem. Aesthetic is in the eye of the beholder. Everybody sees aesthetics differently. These patients are patients of mine that are requested this type of restorations. They think that was highly aesthetic and they loved it. And maybe for some of us, this is disgusting and this is something horrible. So aesthetic requires the knowledge of facial aesthetics coupled with the knowledge of natural tooth position. Usually when we walking in the street, you start with the individual general appearance, and then you move to the particular of a single tooth. So when we see people from a distance, a general impression is developed. And as we move closer, our focus shifts to the face and to the teeth. The most important attractiveness characteristic is the general appearance of a person and the face. The eyes and the mouth are facial features most commonly associated with facial attraction. They produce emotional expression, they are the moving part of the face, and they play an important role in recognition. So when we look at the patient and we want to do a facial analysis, the first thing we look at is the frontal view. We also will look at the profile view. We'll go over that later. But when we look at the frontal view, you first of all look at the interpupillary line and the commissural line. These are the horizontal reference lines. They're very important. They need to be symmetrical. Symmetry means that all these lines are kind of parallel to each other. Now, there is a mild degree of asymmetry, in general, 3%, that is common in the face of normal human individuals. The nasal architecture plays a crucial role in the perception of symmetry. Diversity is the other thing you want to look at. An aesthetic composition involves an arrangement of elements conceived around a unifying principle. And this is what we call unity in variety, but with sufficient diversity to create interest in the eyes of the observer. And this is what we call diversity in unity. This harmony is when an ideal harmony between the interpupillary line and the commissural line in relationship to the horizontal plane is lacking. The midline is the other thing you want to look at. Now, unfortunately, some people, their midline is off. They have a disharmony, which means that the midline of the face does not coincide with the midline of the teeth. And this is something you need to be very careful not to promise the patient that you will be able to fix it. Because depending also on the distance of that discrepancy between the middle of the face and where the teeth are is something, the more the distance, the more the difficulty in providing the patient with something that they're looking for. The other thing now is to look at the facial thirds. The distance from the nose to the lower edge of the upper lip is equal to half the length of the lower lip to the chin. Ideally, there's no effect on the facial height and facial aesthetics when you go from the VDR to MIP. Now, let's look at the lateral views. Let's look at the profile. The nasolabial line angle. This angle changes following prosthetic treatment, and it's very expected. So don't make changes to the dental position that would interfere with the muscular area composed of the tongue internally and the lips and the cheeks externally. Now, this angle varies between men and women. With men, it's around 90 to 95 degrees. With women, it could be like 100 to 105 degrees. Restorative dentistry has a slight effect on lip position. So by positioning the teeth in a more lingual or labial location. Now, again, if a patient wants to change that nasolabial angle, that's not something you will be able to do with your crowns. When we also look at the profile, we look at the E-line. This is an imaginary line that is drawn from the tip of the nose to the soft tissue pogonium, which is the most prominent point of the chin. According to Robert Ricketts, a prominent orthodontist, he found that the upper lip is usually 2 to 3 millimeters behind the E-line, and the lower lip is approximately 1 millimeter behind the E-line. So if you look at that patient, you notice that his lower lip is too far backward. So if you want to push that lip forward to make it like 1 millimeter behind the E-line, you will not be able to do that only with your crowns. You're going to need some orthodontic intervention. The other thing, we look at the profile. We want to know if a patient has a convex or a concave facial profile. It's not effectively altered by restorative treatment alone. So if a patient is a class 3 and you think that you can bump up the upper lip with the crowns and adjust him from a class 3 to a class 1, is practically not feasible. Cephalometric analysis to confirm the diagnosis is extremely important. And most of the time, the treatment of these patients is both ortho and or orthodontic surgery. And then once these are done, then you can intervene yourself with some restorative treatment just to improve the shape and the look of the teeth. We also look at the lips. Usually, we want a tooth exposure between 1 to 5 millimeters. Of course, with the ladies, they want to show a little bit more than men. So the lip or the tooth exposure depends on the height of the lip, the age of the patient, and the sex of the patient. And you notice if you look at the numbers here, that women at rest, for example, in average, they show 3.40 millimeters, when the men at rest show 1.91 millimeters. So with you, if your patient is a woman, you have to expect that they show a little bit more tooth exposure or incisal edge than men. and also young patients show more teeth than middle-aged patients. Age can diminish tooth visibility because of the abrasion of the teeth and the reduction in perioral muscle tone. So always evaluate the maxillary incisors at rest for the restorative treatment. Now, when you look at the population incidence and the public preference of the curvature of the maxillary anterior teeth and the lower lip, you notice that in general, the incidence of parallel teeth to the lower lip is higher than all the other types of composition. And this is basically what also the public prefers. They prefer the upper teeth to be parallel to the curvature of the lower lip. Now, when you look at the maxillary teeth position to, in relation to the lower lip proximity, it's very common that the upper teeth are not touching the lower lip. And this is also what patients like to have. So take these into consideration when you're designing crowns, specifically if your patient has excessive wear and teeth have been severely damaged. The other thing you want to look at is the aesthetic principles. For shortness of time, I can go all over them, but I'm going to quickly talk about we need to look at the symmetry and proportions of the teeth, the incisal arrangement of the embrasures, the axial inclinations of the teeth, and then this could be also adjusted with your provisionals before you move to the definitive restorations. The gingiva design, the gingiva design also could be altered by some periodontal treatment and sometimes some ortho treatment. Tooth proportions, facial harmony, and smile arc. The most beautiful smile is when the teeth have a gull wing effect, that the central and the canines are approximately at the same height, laterals are a little bit shorter. So when you get patients like these that have worn down their teeth severely, there should be a plan. You can't just jump in and say, okay, let's prepare the teeth and get it done. Sometimes you have to evaluate the vertical dimension, evaluate why did they end up with so much wear, so much abrasion of their teeth. Why did they end up with an inappropriate smile? That you have to analyze all of these things. And sometimes, most of them, you need to figure out what type of material you want to use. If a patient is a heavy bruxer, you're going to be careful using lithium disilicate. But you're probably better off being with zirconia because it takes a little bit more load to fracture. So the choice of material and stage selection is the second thing you want to think about. And you notice the choice of material is done even before you start preparing your patient. Now, when I have a patient like this, he has already damaged all his PFM crowns, bite collapse, implant failures, then I know that whatever I'm going to give him, he has the potential to break. So there is this little new device called the InnoBite that I've been using now. It's a Canadian company that came out with that device. And basically what it does is it measures the biting force to tell you exactly how much force is the patient applying when they bite together. Now, that number is crucial because also it helps me convince the patient that, hey, pal, you biting 1,536 Newton. And if you look at that reference values, now you are in the excessive bite force, which means that you can break anything. And you've already broken your teeth. So first of all, I know that at the end, I'm going to give you a night guard. And second, I know that I'm going to go with zirconia. And you notice also that that device gives you the biting force both on the right and on the left of the jaw. And particularly for that patient, he had more biting force on his right than on his left. So patient like this one with moderate to excessive wear will always have a class 3 tendency. They are a pseudo class 3. So because they lost vertical and he has a reverse curve smile, when he closes, when he bites down, his mandible has the tendency to move forward and he looks like a class 3 patient. But in reality, he's not. The important thing at that stage is to measure the difference between VDR and MIP and figure out how much substance did he lose. So to know in which directions you are going to move. Are we going, for example, to do root canals with posts and crowns? Are we going to extrude these teeth? Are we going to extract them? So again, there should be a thorough evaluation, endo, perio, pros, all of the above are needed to be able to put together a treatment plan for the patient. Now, but sometimes it's very difficult for the patient to realize how I'm going to look like. And they ask you, doctor, I can't even conceive how I'm going to look like. Or you're going to tell them, oh, I'm going to give you some beautiful crowns and everything, but they can't see it. So this is an amazing tool that you can download on your cell phone or on your iPad. It's an Ivoclar Smile augmented reality app. It's something like $39 a month. And then what it does is you just take a photo and you press the edit button. And here you have the possibility of either going for a bleaching or shape of the teeth. Now, for example, I'm a heavy bruxer. I go with shape. I want an advanced workout done. I'm going to pick up that these are my natural teeth, and I'm going to pick the shape of the teeth that I want. Then the software is going to ask me to adjust the new teeth. I'm going to shift them vertically, horizontally. I'm going to rotate them vertically and laterally, and I'm going to shift them back and forth if needed. And then once I have approximately what the patient needs to look like, I'm going to show them the final result with AI. And you notice on your left, there is a little cursor at the bottom of my chin, and you can take that and take it right and left, and then we'll show you the before and after. And you can share these with either the patient or your lab technician. So the key value of such an app is you have a real-time visualization of aesthetic option directly in the patient's mouth. An amazing diagnostic tool, an amazing marketing tool. Patient will see what you want to offer, and they will directly on the spot can interact with you and move forward with the treatment. If you need adjustments and final visualization, they can be shown chairside, that you don't have to send it back to the lab and adjust the wax up and so on and so forth. The other thing I've been using is the SmileCloud Biometrics. What it does is you take a photo of the patient, you take an intraoral photograph. This happens to be a complete denture patient, but the same principle applies for a dentate patient. Now here, it generates some videos by AI, and the patient didn't like that smile. She thought the teeth were too big, were too wide. She showed a lot of pink. So I adjusted it, and you notice in the extreme right, you notice there is a cursor that I'm moving right and left to be able to show the patient after we discussed of the treatment that she wanted and the outcome. And then she was very happy with the outcome, and she said, okay, let's move forward. The other thing you want to do is a tooth shade and soft tissue stage selection. Now, again, if you're doing pink ceramics and you know that your prosthesis is going to be an FP2 or an FP3, and then you will show some pink ceramics, you need to take some shade guide. Now, conventionally, we use the Vita Shade Guide, we use the Vita Guide 3D Master, or we use the Vita Easy Shade 5. Now, there's a new device that I've been using also in my office. It's called the Cobra Shade Scan. This is a spectrophotometer, and what it does is it allows you to acquire the spectral data over the entire tooth. The wavelength are analyzed and then compared to a database in order to deduce the color of the tooth. You have a little LED screen on top of my thumb, and then this one, when you press on it, you take a photo of the tooth, and then this goes into a software that will analyze the shade of your tooth. With it comes a little app, and that app will allow you to take up to 4 photos that you can share with your lab technician. They are not saved on your smartphone. They go directly into the software. Now, one other thing is that you get, sorry, I keep pressing the wrong button. And what you get here is you get a polarized picture. You get an overall shade. You can get a 3-part shade if a patient has a multi-layer shade. You can get a 9-part shade. And if you're doing a composite buildup, you can do a detailed mapping, and then the software will really show you kind of where you need to put all these little composites to obtain whatever you're looking for. And it will also give you a translucency. Now, this also, the software will also give you a colorimetric tool, which gives the lab technician all what they need to provide you with a highly aesthetic restoration. Now, when you look at the tooth preparation, there are 3 finish line forms that have been used with all ceramic crowns. Shoulders with the sharp axial gingival line angle, shoulders with rounded axial gingival line angles, and chamfers. Now, again, you can use any burr you want, but this is what I personally use. I mean, everybody uses different things, but I like to use parallel-sided burrs like a torpedo shape. The reason why is because if you have the tendency to angle your hand a little bit, if you use a tapered burr and you angle your hand a little bit, then you're going to have a lot of tapering of your teeth. You want a taper between 5 to 8 degrees. And if you have the tendency to over taper, it's better to use parallel-sided burrs. And again, for the occlusal surface, I only use the 811 to get a uniform reduction. And then I smooth everything with the Brownian greening. Now, the burrs get dirty in them because of the powder that got stick to the diamond while you're grinding. I use these little diamond cleaners from Ultradent. I find them very efficient, and I like them. The shoulders with sharp axial gingival line angles can be formed using burrs such as the 56L to create the sharp internal angles and smooth using a hoe. Now, if you're not comfortable using a 56L, you can use a diamond burr that has a 90-degree bottom end, and I will show you how to use that in a video later. Shoulders with rounded axial gingival line angles are formed using diamond instrument with a rounded tip. Now, again, everybody has a preference for how they do it. The most important thing is that your prep needs to be super round, super smooth, because if you're using intraoral scanners, the scanners and the softwares cannot read sharp angles, and the mills cannot mill anything sharp. That's why everything needs to be smooth, everything needs to be round. And if you stay juxtagingival or supragingival, it's much better than going just under the gums, because you will have difficulty getting these with an intraoral scanner, specifically if the margins are very deep. Chamfers are formed using diamond instrument with a rounded or angled end. Now, when placed into the tooth a distance that is half the instrument diameter, a chamfer finish line is formed as the instrument is moved around the perimeter of the tooth. Now, to facilitate accurate fabrication, what you want to do is to follow the you don't want to go in the interproximal area. You don't just want to go straight, like from the margins of the buccal all the way straight. You have to follow the papillas. Otherwise, you're going to violate the biologic width. Sometimes you need to go deeper into these areas to give the technician some room to give you a good emergence profile. Now, due to the presence of interdental papilla, interproximal finish lines are located further incisally than facial or lingual finish lines. That's why, again, it is important that you don't just dig in there in the interproximal area very straight, because you can violate the biologic width. You can do it a little bit, but it's important to take a perio probe and measure and find out how much leeway you have to do that. For example, this patient had a crown that kept falling off. You notice all what I did is I tried to get the mesial and distal wall as parallel as possible, and I dropped the margins interproximally. Of course, after measuring, I found out that I have a lot of room to do that. Look at this one, same issue, over tapered. Now, all that you have to do is use parallel-sided burrs and then prepare the teeth to be as parallel as they can be to each other. Drop the margins a little bit interproximally to give the lab technician some room to give you an emergence profile of your crown. Watch for the lipping. It's very important. If you use a round burr, you will have the tendency to get a little lip. And then what you want to do is take another burr, and then you can smooth that, or with a hand instrument. So this is how we do it. You notice when you prepare, you have a little lip. So what I do is I tilt the burr tiny bit, and you notice here, I'm gonna tilt the burr tiny bit to just kind of remove that lipping and make sure that my area is flat and smooth. So you see how I do it, and I angle my hand a little bit, make sure that everything is smooth. Supragingival, no need to go subgingival at all. So therefore, when the soft tissue environment permits, it's prudent to minimize incisor-cervical undulation in the finish line. However, creating a facial-lingual flat proximal finish line is not biologically acceptable on most anterior teeth, since the finish line may encroach upon the interproximal biologic width. When you prepare, use depth grooves that will give you uniform reduction. With all the experience I have, I still do that. I use a burr that has a diameter of 0.8 to 1 millimeter. If you sink the whole burr in, then you're gonna get 0.8 to 1 millimeter depth. And then all what you wanna do then is just blend these together, and then you get a uniform reduction of the facial surface. Now, what you want is you wanna make sure that you get a little divergence between like 5 to 8 degree taper. You don't want perfectly parallel, but you don't want over taper. So what I do here, you notice the depth grooves are prepared first. And then once they're prepared, then what we go ahead and blend all of these together. And it becomes way easier because you know how much you have to reduce. I know some of you have experience and you feel comfortable doing it without depth grooves, but depth grooves really help a lot. Now, the lingual needs also to be reduced. That lingual area needs to be parallel to the buccal area that you just prepared. So you also need a 0.8 to 1 millimeter finish line and a total occlusion convergence between the two of them, 10 to 20 degrees. Now, what you want also is a uniform proximal reduction that facilitate the development of normal appearing proximal color and translucency. Now, if you have teeth that are missing substance, it's very important to build them up in order to get retention and resistance form. Now, appropriate convergence angle is important. Now, again, excessive parallelism can be an issue, specifically when you're cementing the crown. It could put a lot of stress into the crown and sometimes can cause fractures of the crown, not the zirconia ones, but the lithium disilicate. So it's important that you also reduce the incisal a good 2 millimeter. And how you do that? By increments. So you can take a burr that is 1 millimeter, sink it in there, join these together, and then add another millimeter, and then at the end, smooth everything together. To reduce the adverse leverage on the crown, it's proposed that the incisor-cervical dimension of the prepared tooth be at least 2/3 the incisor-cervical dimension of the crown. Now, short tooth preparation permit adverse leverage to be applied to the crown when occlusal forces are applied to the incisor ledge, leading to crown fracture. Now, the reduction on the lingual is 1 to 1.5 millimeter. You don't need more than that. Now, once you have everything prepared, you can go ahead and smooth everything with either a red stripe diamond burr or a Grouni and a Brini. Now, if you under-prepare, there was always a fracture that is going to occur. And these failures happen because the teeth were under-prepared. Again, when you prepare the lingual, use a football-shaped burr and make sure that you ask the patient to close and evaluate that you have enough clearance. Again, you have to round everything. Everything needs to be smooth. Scanners don't read sharp angles, and milling machines cannot mill sharp angles. Everything has to be round and clean. Sharp angles could be rounded, and it's very important to do that. Look at your preps and then make sure you round everything. Occlusal reduction of 2 millimeter in the molar area is also a must. If you want to have a crown that looks anatomical and looks beautiful and pretty, you need to give the lab technician room. If you under reduce, like for example, in that particular case, ceramics will be very thin and it will break long term. Important to have, again, a 2 millimeter clearance. Now, when I receive failures in my office, I always look at them, and I sometimes make mistakes too. I evaluate my mistakes, and I know that, dang, maybe I forgot to do that, or I didn't sleep well last night. So when you prepare the teeth, always hold the burr parallel to an imaginary axis that goes inside of the tooth. Now, try not to angle your burr, just keep it parallel to the axis of the tooth. And then let the burr do the job. It's not you that has to prepare the tooth. You just holding the diamond so it does his job. That's why it's important to use new burrs, clean burrs that will do the job and will not heat the dentin and the pulp and fry them. So again, you notice it's just gentle movement back and forth and let the burr do the job. Stay, supragingival. You don't need to go crazy. In the old days with PFMs, we had no other option. Now, interproximally at this stage, what you want to do is take a smaller burr, pointed burr, if a 170, a 170L, or whatever you're comfortable with, and then break the contacts. Don't use that same burr to break the contacts because you can damage the teeth that is close to it. Let's talk a little bit about tissue management and definitive impressions. Because of shortness of time, again, I'm not going to go over the definitive impressions, analog or digital. I will just tell you about tissue management because this is excessively important. So prior to tooth prep, what I do is I pre-pack healthy tissue with non-impregnated retraction cord that will act like a buffer zone to prevent laceration of tissues during high-speed cutting. Don't leave the cord more than 30 minutes. So when packing, exert normal pressure, not a heavy pressure. And after prep and temp, wait for 2 weeks before taking an impression. Now, this is especially for all these big cases, specifically the anterior cases where aesthetics is an issue. Final impression shouldn't be less than 8 weeks post-crown lengthening procedure. Ferric sulfate is something that people use. If you use ferric sulfate, make sure that you clean your abutments with the spot remover because ferric sulfate will impregnate into your PVS. Now, if you're using an intraoral scanner, that is not really an issue. It could be because that spot could leave like a little thickness that you don't need. I recommend aluminum chloride. I like to use it in a gel format. The one that Ultradent has is great. I like it. I use it with a little syringe with a dento infuser tip, and then when I go ahead and I tap it on top of the soft tissue. Now, different cords could be used. The Ultra Pack and some other cord. I have the preference for the Unibraid brand, and I'll show you why. They are braided, they're not knitted. And because they braided, when you pack them, they stay easier and they don't get stuck to your packing cord instrument. Now, all the packing cord instruments are serrated. So with the knitted, they have the tendency to get the cord and pull it out. So what you can do is sometimes smooth them a little bit if they're too sharp, but my preference is for the braided. Now, I also use these instruments to push the gums away when I'm preparing so I don't injure the gums. Now, excessive force, like you see on the photo on the left, has damaged the soft tissues, and that required some perio treatment. Now, if you have a lot of soft tissue, very thin, you don't want to damage it. The best thing to use is a perio probe. It's a very gentle instrument and it doesn't damage the tissues. Serrated instrument can lift loosely woven cords out of the sulcus. The periodontal probe is fine. Well, sometimes in interproximally, the packing cord instrument is a little bit too big. I go with the perio probe and I pack it. Now I'm going to show you a video of a 1-cord technique versus a 2-cord technique. 99% of the time, I use a double-cord technique. I put a number 0 first, and I put a number 2 after that, or it depends how much room you have. But you see with the perio probe, you just push gently. You're not pushing towards the roots. You just packing it into the soft tissue. And again, it's very gentle pressure that shouldn't be very abrasive. Now, the one coat technique I like, and specifically not impregnated, is when I'm preparing the teeth initially before I temporize them. The double coat technique is when I'm making the definitive impression, whether it's conventional analog or it's digital with an intraoral scanner. I like to have coat packed because I retract the tissue and I can see my margins very clearly. Now, what you want to see is when you place your cords, you want to see the entire margin of your tooth, whether you're doing laminate veneers, inlays, or full crowns. Now, the provisionalization, I'm going to talk about that while I'm showing you some cases because it makes a little bit more sense than just talking about provisional. This is a patient presented with a dark crown on tooth number 8, requesting a new crown that looks more aesthetic. You notice the tooth preparation, maybe a 3 to 4 degree taper, everything round, margins very clean, smooth. Interproximally, the margins are dropped enough to give the technician room for a good emergence profile and to mimic the tooth that's close to it. If you're doing lithium disilicate, extremely important to give the lab technician the natural dye shade. And then when you put the provisional, notice it has to have the same shape, maybe not the same color, maybe not the same luminosity or aesthetic appearance, but it needs to look similar in shape to the tooth that you're replacing or to the adjacent tooth. And here the patient wanted to bleach. And notice what we do is we send the lab technician a close-up of the teeth to show him the surface detail and the translucencies. So this way, we also take the Vita 3D shade guide, and then we pick the shade that is closest to the tooth number 9. And then what we do, we pick the closest 2, and that's what we're going to share with the lab technician. The lab technician will work on his crown. You notice the beautiful shape, the beautiful incisal edge that mimics tooth number 9, the ideal emergence profile on the mesial and on the distal. And then, I'm sorry, and then when you look at the final results, it's very aesthetic, supernatural, and looks very, very pleasant for the eye. This is a patient that was referred to me, had a full mouth rehab. Nothing was working. He could not function without his night guard. He said, if I take it out, I'll have TMJ and headaches. Now, when you look, he had all these crowns that made of zirconia, but the problem with these is that nothing was in shape. The broken ceramics, occlusion was off, soft tissues inflamed, marginal discrepancy on mostly all the maxillary teeth, marginal discrepancy on all the mandibular teeth. In protrusive, that was the only time that the teeth kind of discluded, but in MIP, there was absolutely no contact on all posterior teeth, absolutely no contact. All the contacts were on the anteriors. Teeth were perforated, the ceramics was broken, inadequate porcelain thickness, midline is off. And remember, with the midline, it's crucial to explain to the patient that you won't be able to fix that because that's a discrepancy that you cannot fix. Again, periodontally, he was very fine. We decided to place some implants instead of having FPDs. And he did, the first thing I had to do is to remove everything and temporize. Milled PMMA provisionals. The reason why you want these, you can realign them, you can adjust them, you can shape them the way you want. They will last for a long time. Composite temporaries won't last. They stink, they break, and they're difficult to repair. Now, they're okay for a 6 unit for 2 weeks. They're okay for a single crown, but they're not okay for a full mouth rehab or for somebody who's a heavy bruxer. Patient like this lost an attached gingiva of number 29, so he had to get that done. Look at the tooth preparation. very ugly, a lot of undercuts. Now, it showed that whoever prepared these teeth has no idea what he was doing. So all what I had to do, and look at the mandibulas, they even worse. The different levels, the undercuts, underprepared, margins are not the way they should be. So all what I had to do is prepare the teeth. Very difficult to prepare after somebody who has messed up. You notice tooth number 7, I had to really kind of remove the undercut, but I did not touch the lingual much. Tooth number 8, I adjusted the buccal, not the lingual. I adjusted the margins a little bit. Number 9, same. Number 10, I couldn't do much. It was already over-reduced. And again, so you're limited to how much you can do. In the mandible, I had a little bit more leeway. And then important to grab an X-ray before you prepare the teeth to know how much you can reduce. Now, after I cleaned, I put the provisionals. This is my blueprint. He has to wear them for 2 weeks to check occlusion, phonetics, aesthetics, lip support. And again, the funniest part is I didn't give him a night guard, and he said, I'm not going home. I said, you are, because he's close by my office. So I said, look, in case you have any pain, I will make the night guard for free for you. So he said, okay, that's a deal. So he went for 2 weeks. His pain was gone. He couldn't believe what was going on. Important when you do these PMMAs, use pumice, flour of pumice to polish these at the margins, make sure they're super, super smooth. Use a buffing agent to give them a beautiful luster. They need to look similar to what you're going to give at the end. The only thing is they are going to be made of PMMA and not ceramics. You can use some other agents to glaze the PMMA, and that's fine. And this is how the patient was ready for the definitive impression. And this is the definitive crowns as delivered after the lab provided them. Now, if you look here, you look at the anatomy, notice I have enough reduction to provide him with crowns that look anatomically pleasant. If you have to touch zirconia, make sure that you polish. Now, you have an intraoral kit for the Optra Gloss from Ivoclar that can help you do that. But if you also want to do it extraorally, there is also a polishing paste that you can use to do that. This is the definitive results. These are the canine guidance and the protrusive, and you notice the before and after. I didn't do much. I just followed the principles, followed the rules, and I didn't cheat in any one of my steps. Again, look at the beauty of the gums, how they will respond to you, how they will react to a nicely designed crown that respects the biology, it respects the soft tissue. If you look at the lower right image, you notice at the canine area, there is a little concavity, and that gives him room to clean. He needs to be able to put a Proxa brush and clean, and that's how the work was done. And I gave him definitely a night guard to protect my investment and for him to protect his. This is James, 45 years old, has failing lumineers. We're not going to talk about that now. It's not the time. But all what I want to show you is that these are 1-year-old. They are breaking, they are chipping, and he's in pain. Why? He's sensitive. I grabbed an X-ray, and before that, I looked at the protrusive, only one contact in protrusive. Now, if you look here, there's something fishy about that canine. If you look at the X-rays, you notice there's a lot of voids in the cementation. So maybe the cementation process wasn't adequate. So whoever did the job did not even follow the appropriate cementation protocol. And he was sensitive. Now, but that wasn't the problem. If you look deeper, this guy has enamelogenesis imperfecta. And that's why these things, and I understood why they gave him such a super white shade of ceramics laminate veneers, is because they wanted to hide the ugly shade. But when I removed everything, I noticed that there is a big issue. There is enamelogenesis imperfecta, and the other thing, there is a lot of abstractions. So I explained to the patient that he will be better off with crowns and not laminate veneers. So this is when I prepared the teeth. Again, I do the first prep and I pack cord that are not impregnated. I prepared the teeth, put the provisionals in, and this is after the mandibulars were prepared. And look, shade, natural dye selection, and then you give that to the lab technician. and then you put the provisionals. Provisionals, the juxtagingival, you don't have to go crazy, highly polished, but the most important thing is in protrusive, he has contact. In working right and working left, he has disclusion in the posterior area. That's what you're looking for. You test these for phonetics, for aesthetics, for lip support, for occlusion. You want to make sure that the TMJ doesn't hurt. And then the lab technician, if you provided him enough room and a good impression, whether analog or digital, he can see the margins. He doesn't have to do guesswork. He can give you with crowns that have ideal emergence profile, beautiful anatomy that looks gorgeous. What you want to do at this stage is you want to try these crowns, isn't it? So one thing we recommend is to use fit checker. I use black. It's a silicone material that you mix base and catalyst. You put them in the crowns and you seat them on the preps, and that will show you if there is any areas that are binding and heavily touching the prepared tooth, and you can adjust. If you need to adjust at the end, I will tell you what to do to clean these entirely surface of the zirconia. And this is how he ended up. Now, I don't like the shade, but this is what he wanted. The funny part is I always have the patient sign a paper that this is what they want and they're happy with it. Why? Because what happened with that guy is I think 3 months later, he came back and he said that he wanted to change them. They were too bright. And I said, well, if you pay me, I'll do them again. But, and then he kept them. But again, it's very important that they understand that these look like sink white and they're not really fun. But again, phonetics, aesthetic, lip support, look how aesthetic it looks when you follow the rules, follow the proportions, follow the facial analysis that you looked at, evaluate the bite force and all. And again, the biggest investment you can do for yourself and for the patient, anytime you restore all these anterior teeth, is to give them a night guard. This is a patient came in with issues with her smile. You notice teeth were very short. What we did is a composite mock-up to show her how we're gonna lengthen these. Now, after we prepared the teeth, the shade was taken, dentin shade was picked, and after we gave the technician an amazing impression, he has no reason what not to give you beautiful crowns. Look at the good emergence profile. Look at how nicely the crown look, incisally, the harmony of the teeth, the aesthetic appearance of it all. And then again, the uniform thickness of your preparation, extremely important. The smoothness of the margin, you give no chance for the lab technician to give you a crappy job. Now, again, this is as soon as you remove the provision, you notice these provisionals were for 2 weeks in the patient's mouth. Usually, the margin needs to be highly polished, excessively polished, and then the patient needs to understand that they need to keep it clean also. Look at when you remove the provisionals, how clean these gums are. And then when you cement the crowns and look after 2 weeks, how beautiful the margins are, how beautiful the gums respond to the material. Now again, zirconia, lithium disilicate are amazing materials that the gums usually like, and then they grow around. Again, this is how beautiful these look. And even with the close-up, you notice there's no inflammation, no issues, and it's very clean and neat. And again, aesthetically, it looks very pleasant and it blends. You see, it follows the lower lip, and that's what you want. And that's what mostly people, what they want. The center is a little bit longer than the canines. Lateral is a little bit shorter, and everything blends together. Again, the midline, there's a limit how much you can change. Don't promise. The lip support, there's a limit to. Now, sometimes they want more lip support. What you can do is refer them to somebody who can do collagen or fillers, and that will improve their lip appearance. But this is not something we can do with our crowns. Now, when you look, again, that's a before, and this is after. Notice that the patient had a reverse curve smile, severe wear of the teeth. And again, by changing these crowns and blending them with the other teeth, how natural everything looks. Again, a night guard is a must, and it's a protection for the investment that you do. And finally, I want to talk about cementation. What you want is use conventional cementation with glass ionomer cement, resin-modified glass ionomer, or self-adhesive resin cement. Many manufacturers recommend air particle abrasion or what we call sandblasting before cementing, especially with self-adhesive resin cement for improved bond strength. Now, air particle abrasion with alumina and MDP-based primers provide higher bond strength of resin-modified glass ionomer to zirconia. Alumina airborne particle abrasion of the intaglio zirconia crown is beneficial in retaining the crown regardless of the cement type. After you try in the crowns, you need to clean them because they'll be contaminated with saliva, with blood. The most important thing is to put them in alcohol in an ultrasonic bath for 5 minutes while you're getting everything ready. Or what you can do if you don't have an ultrasonic, what you can do is use a zirconia or ceramic cleaner. All the companies have that. Doesn't matter, buy whatever you want. Now you condition the tooth with a mild solution of polyacrylic acid. Now this is with the it's a Riva conditioner, and I'm going to talk about that because this is this cement is my favorite cement, and you're going to apply the cement and seat the crowns. Now the Riva Cement Automix is my cement of choice for zirconia crowns. It's a self-curing, radio-opaque, fluoride-releasing paste, and it's indicated for permanent cementation of metal-based and strengthened core ceramic restoration. Now, it could be either high strength, which is like zirconia and lithium disilicate, or it could be used for low strength ceramics, which is like feldspathic porcelain or glass ceramics. You can also use it for PFMs, prefabricated cast, metals, posts, inlays, crowns and bridges. You can use it for anything. Now, if you compare the Riva Cem Automix with resin-based cement, you notice that the Riva cement is a moisture tolerant, releases fluoride, might not be very aesthetic, but you need retention. When you use resin modified glass ionomer, you need retention. So if you don't have retention, let's say you over prepared or the clinical crown is short, just go with self adhesive resin cement. Now, when you compare Riva to the competitors like Fujisem 2, Fujisem Evolve, Relax, Lutin, Plus Automix, or Nexus resin modified glass ionomer, you notice that it has the highest flexural strength, it has the highest viscous hardness, and it doesn't waste as much material, and I'll show you why. And then again, it is you can tack cure it, and again it sets in nearly 5 minutes. It's very easy to use. There's nothing complicated. What you can do is use the conditioner if you want, just to apply it to the tooth, and then what you do is just clean the entire surface of your crown, apply the cement, and seat it. It is contraindicated, now highly contraindicated for pulp capping. If patients have skin irritation, what you can do is just discontinue and seek medical attention, an allergy specialist. If any patient are known to have allergies to resin, they might tell you, I'm allergic to resin, just don't use it, or if you use it and you didn't know, just discontinue using it. Now, I've had the chance to review the product, and I can tell you one thing, that this material has an excellent bond to enamel and dentin. When it was left 6 months, they did the test, simulated 6 months. They realized that it has an excellent bond to enamel and dentin compared to other cements. When they look at flexural strength, also similarly, it had the highest flexural strength when compared to other cement. And then when you talk about waste, the Rivasem Automix, the tip is very, very small compared to the other tips. So you have really much less material that is wasted than with the other competitors. And when they did the study, they found that the waste per milligram per tip was 0.21 compared to the others that had approximately a little bit more, and some of them had even the double. A recent review by the clinicians report from Gordon Christensen's foundation found that 75% of the 24 CR evaluators stated they would incorporate Rivasem Automix into their practice. 79% rated them excellent or good and worthy of trial by a colleague. Now, as a conclusion, facial analysis and smile design are crucial in establishing a treatment path. Digital workflows are possible and predictable. Choice of material and shade selection are an important element of success. Make sure you go over these before you do anything else and write them down. Tooth preparation, especially with intraoral scanner, is very important. Even with intraoral scanner, you need to use tissue retraction. Now, some people disagree with me. Now, if your margins are supragingival, there's absolutely no worries. But if you have a little bit of subgingival or juxtagingival margins, it's better to get a tissue retraction. New workflows facilitate multidisciplinary care in a simplified manner. And resin-modified glass ionomer is my cement of choice for all ceramic crowns. With this, I'd like to thank all of you for your attention. If you have any questions, you can either email me, you can either text me on Instagram or on Facebook, whatever is your preference. And here I have 3 minutes left or more, and I'm more than happy to stay with you guys. If you have any questions, I'd be more than happy to entertain these questions. Dr. Billings is asking, what are my thoughts on elective endo to regain video with crowns? Now, when you have a loss of vertical dimension, what you want to do is, first of all, find out how much substance you lost. Now, if you know that after preparing these teeth to make crowns, and let's say you're replacing 6 millimeter of tooth substance that was lost, you know that you don't have enough resistance and retention foam, and you need to get that from somewhere. At that stage, yes, you're going to need to do some root canal just to get some posts in there to make sure that gives you some more substance for the crown to hold on to and give you more retention and resistance foam. So that's why the post and the endo and the post is to hold to the core to the tooth. That's all what it does. Do you use retraction cord? Somebody asked. I use retraction cord 99.99% of the time, except if my margins are way supragingival. Why would you choose sharp finish line, and what material impression will you use? I don't use sharp finish line. My finish line are always smooth. Oh, you mean the 90-degree? Well, sometimes if you want to use, let's say, PFM crown, and then you want to do a porcelain margin, yeah, you're going to have to use a sharp finish line. But in general, my preference for finish line is just a chamfer. It's kind of a smooth, wide margin that the scanner can take. What material impression I use? I use PVS, and sometimes I use my intraoral scanner. Now, it depends on the difficulty of the case. I still like to use my PVS when I'm doing full mouth rehabs. Is there a 2 millimeter occlusal clearance? Do you recommend gold or PFM crown with metal occlusal so the tooth is not reduced to a pancake, or would you bond the crown in number 18? I don't know what you're referring to, but yes, you need a 2 millimeter occlusal clearance if you're aiming for an all ceramic crown. If you don't have that, that's okay. You know that if your crown is short, you're going to have to use resin composite cement. You can't use resin-modified glass ionomer for your retention. Now, do you recommend using fresh new diamond burrs for crown cutting? If you want to remove crowns, yes, specifically if your teeth are vital, you would need to use fresh cutting diamond burrs. For cutting the crowns, what I buy these cheap single-use diamond burrs, and I burn a lot of them, so I don't feel bad. And again, some manufacturers, burr manufacturers, have specific burrs that you can use to cut zirconia and take them out. Regarding you using resin modified glass ionomer with lithium disilicate crowns. With lithium disilicate crowns, I use usually multi-link, but with zirconia, I used Rivasem, which is the resin modified glass ionomer. Any thought about use of chlorhexidine to disinfect the tooth previous to crown cementation? You have to be cautious with chlorhexidine. Yes, it could help you clean, but you have to make sure that you remove all the residues before you apply your cement. Do you need to splint for all post-treatment FPD cases? If for the provisionals and for the ease of removal and placing, taking out and putting back the provisionals, yes, it's easier to have the provisionals in one piece and much easier to do that. Thank you for a terrific lecture. Thank you for the compliment. What is the name of your lab? I have my own in-house lab, but I also use Lee Culp for all my full mouth rehabs. I use Burbank Dental Lab for some of my full mouth rehabs. It's first, and I use Cusp Dental sometimes. Do post strengthen endodontically treated teeth? No. Post do not strengthen the teeth. The role of the post is to retain your core. Should all endo teeth be crowned? Yes, that's my humble opinion. Specifically, the posterior teeth. In the anterior teeth, if you only have an access hole, let's say tooth number 8, and you only have an endo access hole, tooth is intact, there is no need to put a crown. You just have to put a composite filling. You can read my book. I have a book that's published at Quintessence about that topic. Do you recommend ortho before pros to establish proper arch width and make certain only vertical forces on the teeth? Yes, depends on the case. That's why you have to do your due diligence before you decide to do ortho or no ortho. Is it advisable to harmonize a bit the opposing tooth in case of tight interocclusal clearance? Yes, it's not a big deal, provided the patient understand that you're going to do that, why you're going to do that, explain that it's not dangerous, and get their consent. You can't do it if they don't consent to you. Because if you start prepping and they say, I didn't tell you to do that, they can sue you, they can get you in trouble. Always get consent. Do the phosphates in chlorhexidine interfere with bonding? Yes. Somebody asked me that question before. That's why we do not recommend chlorhexidine much. What's cement for Emax? I personally use Multilink. I like it. I've been using it for more than 15 years, and I have no problem with that. What was the name of the app to show patient the smile makeover? Okay, it's an Ivoclar Smile app. If you go on the app and then I'm just double checking for you, but it's called Smile, just Smile, and it has like a bar and a lip, and from Ivoclar. It's $39 a month. Pseudo class 3 cases, what is your recommendation for FPD material of your choice? Now, if they are in pseudo class 3, that means they wear the hell out of their natural teeth. And that's why the mandible moves forward and upward, and they look like a class 3. So in that case, if you open the vertical, you need to do zirconia. The reason is, once you open the vertical and put the provisionals, if the provisionals are not done properly, and if the teeth and the provisionals are made very steep, they can cause the fracture of the provisionals and the teeth underlaying. That's why it's important to know how much you have to open, put the provisionals on the patient on provisionals, Let them try it for two weeks. Make sure that they're comfortable. Make sure that phonetics is fine, aesthetics is fine, occlusion is acceptable. And after that, move with zirconia crowns. Thanks, good piece of information worth the time. I'm glad you like it, and I'm humbled by your opinion. How to determine VDO and CR? Okay, the VDO, what you determine is you use the same principle that you use for complete dentures. You remember for complete denture, you measure the vertical dimension of rest, you put the dentures in, have the patient close, and this is your vertical dimension of occlusion. And then you subtract the difference. If you have 2 to 4 millimeter difference, that means the vertical is okay. But let's say you have 9 millimeter difference between VDR and VDO, that means the patient lost 5 millimeter of teeth. And this is how you do the same with natural teeth. You have put them at rest, measure the vertical dimension at rest, have them close, measure that, and look at the difference. Anything between 2 to 4, you didn't lose vertical. Anything more than 5, you lost vertical. Centric relation, there's many ways of doing it. You can either manipulate the patient, but if the patient is difficult, has a lot of wear, just you can use a Lucia jig, and then it's a deprogrammer, and then you can also buy it. My memory now is I'm tired, but there is a device that you can buy from a company. It's like a leaf gauge. What you can do is with the leaf gauges, you determine how much you want to open the vertical, and then you keep it in and have the patient move forward and backward, and then that will put them into CR. So that's as much as I can tell you quickly in a couple of minutes. Any other questions? When doing zirconia crowns on anterior teeth, do you do FCC or PFZ 3/4 with only porcelain on the facial? Now, depending on the patient, if they're heavy bruxers, no, I'll go full contour. It's much better for me, so I don't take any risks. But if they're not bruxers, but you just adjust, then yes, I'll do layered zirconia, which look much more pleasant. Do you use pins? What to do with second molars who are difficult to get proper form of retention? I do pins not often as I used to. Today with bonding, with resin composite cements, you don't need that much, but yes, I do them if needed. But I don't use them to add a lot of material. It's just needed to add a little bit here and there. Thank you very much for an excellent lecture. I appreciate your comment and I'm humbled. Thank you very much. I'm glad you like it.